Thank you, Eric. You didn't tell me when I talk about difficulties to introduce new things. 15, 20 minutes can barely start on any of the 4 items on this topic that Eric gave me. However, let me try. I started practicing in July 1978, and of course, the younger surgeon in the group, they give the worst day to operate, Friday afternoons and Monday mornings. So I'm operating an 80-year-old lady, replaced a mitral valve, which I thought was a well-done operation. Finished the operation, and suddenly the chest tubes, the bright red blood, as I was closing her, and I took a look in the heart, there's a hole in the back of the heart. The posterior wall had a rupture, which is one of the complications of mitral valve. And as a resident, I had seen 2 or 3 times, and they all die on the table. So I went back on bypass, and I started to think there's a hole in the heart from inside outside. And as a thinking surgeon, I took the valve out and put a patch in the hole from within, her own pericardium patch. Put a valve back in, was like nothing had happened. Mrs. Davis, her name, she lived for another 15, 20 years. She lived for 15, 20 years because I followed my patients. I follow every single one of my patients, all the 16,000 I have operated on. This is part of the talk. Well, it worked for Mrs. Davis to patch a hole. Next day, I had a heavily calcified, a MAC. And nobody would touch a MAC in the 1980s. They're afraid to remove the calcium, the patient died. Actually, in the surgical literature, MAC in the 80s was described as the bar of death. If a surgeon touched it, the patient died. Well, I had one perforation in the heart, put a pericardium, and she lived. Why shouldn't I take the calcium out and put a large band of, or an abscess in the mitral annulus, or multiple reoperations? This is 1978. By 1980, I have done 20 or 30 patients with patches everywhere in the heart. And every time we do, of course, we have to publish it. By 1985, I was pretty experienced in putting patch in the hearts. And a new problem. What happens if the whole base of the heart is calcified, or if an abscess destroyed the whole base of the heart? Well, separated the ventricle from the atrium. Take everything apart. Rebuild with a patch, Dacron, or pericardium, bovine pericardium, and put 2 valve ins. A new operation was developed. So by the end of the 80s, I had developed 15 or 20 new operations, and all based on the same philosophical viewpoint. You have a problem, you have one potential solution. If worked, you move to the next step, then next step, then next step. Keep expanding to determine the limitation of the procedure. And of course, you have to publish all the time to let your peers to judge if this is BS or if it's real. Well, everybody was dying if they had a ruptured septum, particularly posterior ruptured septum. They come in cardiogenic shock, and this patient just... In 1990, when I moved to Toronto General Hospital, I was a Western then, the intensivists said, rupture posterior septum, you don't call this surgeon anymore. I was the new chief. I said, what do you mean don't call this surgeon? That's a pathology that can be fixed. And the mistake we're making in the past is infarctectomy. Well, infarctectomy means cardiectomy. It means to remove the heart. You can do infarctectomy without transplant. So we came up with the patch exclusion technique. Open the infarct very gently, delicately, and put a patch in endocardium, excluding the part that's infarcted. And guess what? The mortality from 100% went down to 10%, which is usually the mortality that you guys have in acute transmural myocardial infarction without rupture. So you can transform a very high risk condition to publish as well. And unless you publish, you'll never know if what you have done is right or wrong. There's no point in developing a technology that you own and nobody else can do it. Good operations, good devices, good procedures are reproducible procedures. Unless you can teach someone. I was very lucky to have a very good technical surgeon next to me. I developed something, I would teach him. If he could do as well, I published. Those he couldn't reproduce died there and became a domain of one person only, which is not really, there's no any point if you come up with something that only you can do. Innovation in medicine is linked to the human quality called the creativity. If you take a look, if you had the sons, I have a 40-year-old grandson. He's anxious for me to pick him up this afternoon to go for a bike ride. This boy asking me questions continuously, but doesn't stop. We are cycling, we stop at an ice cream parlor, and he goes, what is this? What is it? Why do we lose the creativity? Why do you try to conform to what your parents tell us, what society force us to mold ourselves to? Creativity is an innate quality of the human being. We are creative when the time you're growing up. We keep coming up all crazy or, unconventional, conventional thing, but eventually creativity disappears. I drove my parents insane. That's why they sent to boarding school at 14, and I never saw my parents again, because the Jesuits took care of a Jewish boy, which is a bit ironic, but in Brazil it was acceptable. The only good school was the Jesuit schools. So Jewish or not, they taught me how to behave. Likely, for all the studies on human creativity, Mihaly Csikszentmihalyi, the professor of psychology at the University of Chicago, has done more work than anybody else. I happen to have met him personally, and his books are fascinating. The second one should be part of the medical school curriculum, to be quite honest, because he defines creativity. Some people are genius, but how many geniuses do we know? I don't know any. I heard of Einstein, I heard of Leonardo da Vinci, but most of us are not genius. I have a daughter who has an IQ of 178, but she's a bum. She doesn't do a thing constructive. She changes job every 2 years, and I try to tell her, focus, focus. She's 42-year-old, 3 husbands, hasn't produced a thing yet. So high IQ doesn't guarantee that you're going to make any difference in society. What makes a difference is hard work, is perseverance, is to know your field very well and then try to take to a higher bar. Take a look at this. I don't know if you guys know, if you ever read the book on the discovery of the structured DNA, published in Nature 1953. If you go back in the history, it was not somebody came up with a concoction of 2 spirals with the parents linked together. It's a long, very, very long history. It started in Austria with Gregor Mendel, the discovery of genes. And you all know from medical school the experiment he was doing in the backyard with green peas and yellow peas. The only way a yellow pea could give off a green pea is because there must be something in the parent that brought the gene of the green, just like everything else we do in life, like we are. And then in England, Griffith came up with that the nucleus of the cell contained the messenger. And in our lifetime, the more important was, at least my lifetime, was Linus Pauling description in California that proteins are elliptical, are spiral. The amino acids form a chain, forming helix. Rosalind Franklin in King's College in England. She did some refraction X-rays of the nucleus, and she actually showed the picture that she published. And then one afternoon in October 52, somebody, her boss actually, or the chief of the lab, showed in a meeting like this year what Rosalind Franklin had obtained. 6 months later, Watson Crick published this thing. These are the pictures that, if you go to England, go to London, ever can see the original pictures. Franklin X-ray diffraction DNA. Look at what she obtained. If I was Rosalind Franklin, and I had seen that refraction, I immediately published in Nature the structured DNA. She knew what Pauling had said, that proteins are spiral. Well, look at the picture. If you put two spirals on top of each other, the only possibility is two identical proteins, two proteins that intertwine, making a spiral. Why didn't she come up with the idea, and James Watson Crick came with the idea? They saw, immediately they published. Yet, she got no recognition because she didn't publish. Human creativity results of an interaction of three independent components: a domain, a field, and a person, according to Mihaly, Csikszentmihalyi. Domain is an area for culture. Anything, music, cardiac surgery, what you guys do, congenital heart surgery, intervention in congenital heart surgery. These are domains of our society. Field are the gatekeepers of domain. You come up with something, you publish, I'll criticize you, or I'll endorse what you said. And the person is the one that creates something new. In his book, he analyzed some 500 or 600 creative people in North America. And it's amazing. They all have common links. They all love what they do, love with passion. They are uniformly workaholics. This 9-to-5 thing doesn't exist to a person who's creative. There's no clock, there's no time. And they never lose that thing. My 40-year-old grandson asking me, afternoon is going to be asking me. And they don't want too much detail. They just want an explanation why it is the way it is. He wants to know why when he turns the pedal in his backwards, the bike stops. Inquisitive. I was in the operating room and everybody's saying, hey, there's too much gradient. Rabin Tula had to publish a paper in 1978, introduced the term mismatch. A person coming in with aortic stenosis, the surgeons go in and put a prosthetic aortic valve, and they go home with aortic stenosis. In between, a big cut in the chest and a prosthetic valve in the heart. Rabin Tula introduced the concept. Unless you're going to put a valve big enough to eliminate the gradient, why to do it? The valve on the left was a valve I had in 1980 when I started practicing. It was inside the annulus. It's a very bulky amount of tissue. Very simple idea. Why don't I switch the valve above the annulus? And immediately, Warren Hancock, a maker of a valve, knocked on my door and said, I can make one for you, supraannular. Simple innovation. But improve the gradient by 20 to 30% because remember, 1 millimeter you gain in a peripheral of the circle is not 1 millimeter square. It's times pi, the radius, it's square. So 1 millimeter in the center is 1 millimeter. 1 millimeter in the periphery is immensely greater. Well, what's better? You have to publish it. So I asked Warren, can you give me what to put inside of this bloody valve? In 1982, I asked him. He said, well, this is illegal. I said, wait, why is it illegal? Oh, FDA doesn't allow me to do that. I know, but give it to me only. I said, well, I can't. So I fly to Ottawa. I present the same thing to the Health Protection Branch, very friendly environment back in 1980s. You present a rational approach. They said, well, we'll let you do 25. So I gave the letter to Warren Hancock, gave me 25, Hancock valve without the stent. Stentless aortic valves were invented at that moment. Spectacular hemodynamic outcome, no gradients. You guys look at the echo, say, where is the valve? Where is the prosthetic valve? There's none. Publish again. You have to keep showing your peers what you do. Somebody else have to review, have to examine what you have done in a long list of publications. Didn't work very well. It failed. It failed worse than, not in my hands, but in my colleagues, in my peers' hands. It failed. So it wasn't reproducible. Actually, look at the bottom paper there, the bottom, which published much later, was published not until 2008. It takes 10 to 15 years to prove a point in medicine, not 10 days. We are the first one to publish. Great hemodynamic, great survival, but durability is worse than existing valves. You invented, you destroy it. So it was a good idea hemodynamically, bad for durability of the valve. But the introduction of a stentless valve in 1982 opened the door, in my brain at least, to an entire new dimension on heart surgery. That a valve was very dependent on the commissures. Just like the mitral valve depends on papillary muscles and chordae tension, the aortic valve depends on the suspension of the commissures. Until 1985, no one ever mentioned the role of the sinotubular junction in valve function. And yet, stentless valves such as Ross procedure and homograft have been described in the 60s. How could the surgeon have done all those operations without the knowledge of functional anatomy? We learned that this is very important, and this changed the way the Ross procedure was done, which was a totally chaotic operation to much more scientifically based and worked if you follow the rules of functional anatomy. Lessons learned from stentless valve is the logical progression of innovation. That's the path to innovation. And much more than that. So next day, after I learned this, I'm in the operating room looking at the aortic valve. The cusps are entirely normal, but yet severe aortic insufficiency. So how is that possible? Well, we developed 10, 15 different operations to repair the aortic valve. And we coined a new term, aortic valve sparing operations, which, by the way, 30 years later, is still the best operation to repair the aortic valve when put the valve in a cylinder. Innovation or surgical creativity or what you do unfolds in our lifetime. I think is a stepwise logical progression of ideas and knowledge. Unfortunately, unless you follow your patients, your innovation is going to die pretty fast. And if it is to die, I think it's the obligation of the innovator to kill, not somebody else. Innovation in medicine comes from the past, comes from previous knowledge and experiences. And whatever we do is a continuation. Genius strikes are very, very infrequent, very uncommon in humankind. I think Thomas Edison was right. It's largely 99% hard work and 1% only inspiration. Times have changed. I'm frequently asked, would you have done all this if you start practicing today? Well, you have to use different approach today. I don't know why we became so dependent on or responsive to society. Would you believe that until 2016, I follow all my patients, and they thank me every year. I have more gifts in my home than I know what to do with them. Keep trashing or recycling them for my patients, because they appreciate that 20 years later, I'm still calling them. They stop me. My RMB stopped me calling my patients. So you cannot call them anymore. She's my patient. No, you can't. You can call them if you like, but cannot publish. I mean, it's my patient. I operated a guy 30 years ago. I want to tell my colleagues how they are. You can't publish anymore unless they consent. So I have 2 nurses now doing nothing but collecting consent in 12,000 patients to be able to tell you what's happened to them. Times have changed, not only with the FDA and health protection branch, but society, the rules of society. They are making innovation a major problem. Of course you can overcome, and the proof you can overcome is TAVI. I don't think there's been in medicine ever, particularly in devices, in drugs perhaps, but in devices, there having never been a trial with the same scrutiny of TAVI versus surgical VR. And you guys are winning. The interventions are winning. We're showing that it's safer and it's better. And you know why? Because TAVI is a procedure that, all respect to all of you who do it, that eventually a computer is going to do. Artificial intelligence will take over TAVI. Surgery, you never. Computers never take. Because the human variability on what we do, and the perception, and what the surgeon sees. Aortic valve replacement is not the same than for all surgeons. It's very dependent on the technician. It's much more difficult today than used to be when I started 40 years ago. Innovation now, it goes through much more scrutiny than, but it's not impossible. I mean, it takes longer, I guess. No one is going to be able to keep changing things every year anymore without the blessing of supervising agencies. And I changed my slides here. I'm in practice for 40 years. I still review my data. I still review patient operated 40 years ago to see if anything could be done better than I did. Thank you.